and welcome to today's webinar, Reproductive Issues in Women with Sickle Cell Disease. My name is Dr. Evelyn Lockhart, and I'm the Medical Director of the Transfusion Service at University of New Mexico Health Science Center. I will be moderating today's webinar. Next slide. The foundation of Women and Girls with Blood Disorders mission is to ensure that all women and girls with blood disorders are correctly diagnosed and optimally managed at every life stage. To this end, we aim to provide education to healthcare providers on the medical consequences and unique issues for women and girls with blood disorders. Next slide. Today's presenter is Dr. Ken Smith-Whitley, Associate Professor of Pediatrics at the Perelman School of Medicine at the University of Pennsylvania and Medical Director of the Comprehensive Sickle Cell Center at the Children's Hospital of Philadelphia. Next slide. The Activity Medical Director for today's webinar is Dr. Andra James from Duke University Medical Center. The planning committee for today's presentation includes Drs. Barbara Alving, Jennifer Dietrich, Barbara Conkle, Roshni Kulkarni, Kenneth Mann, and myself. Next slide. In accordance with Creighton University Health Science Center policy, the faculty and planning committee for today's webinar have disclosed any significant financial interests or other relationships of interest relative to the topics that will be discussed during this program. Such disclosures allow you to better evaluate the objectivity of the information presented in the lecture. You may learn more about this at the Foundation's website, fwgbd.org. Next slide. To ensure the best sound quality during the webinar today, all attendees will be muted during the webinar. However, all attendees will have the opportunity to participate in a question and answer session with Dr. Smith-Whitley at the end of the webinar. You can submit your questions during or after the webinar via the chat box in your GoToWebinar control panel on the right-hand side of your screen. We gladly welcome your input. Next slide. This learning activity is offered through the Creighton University Health Sciences Continuing Education Program, which has been accredited for offering 1.0 AMA PRA Category 1 credits for physicians and 1.0 contact hours for nursing professionals. Next slide. The following are the learning objectives for today's webinar. For those who wish to refer to these later, we will record and archive this webinar on our website, fwgbd.org. I now turn the presentation over to Dr. Smith-Whitley.
Good afternoon, everyone. I'm pleased to give you today my presentation on reproductive issues in women with sickle cell disease. I will start with an overview of the trends in morbidity, mortality, and healthcare utilization in sickle cell disease, particularly as they relate to women with sickle cell. I'll then go into challenges related to transitioning from pediatric to adult care services for individuals with sickle cell disease. I'll address the need for reproductive counseling in adolescents and young adults with sickle cell, and then briefly discuss pain as it relates to the menstrual cycle in women with sickle cell disease. I'll discuss in detail options for contraception in women with sickle cell disease and sickle cell trait, and then lead into a discussion on reproductive issues related to chronic therapies in sickle cell disease, focusing on hydroxyurea therapy. Due to advances in clinical care over the last several decades, young children with sickle cell disease are more likely to survive to 20 years of age. Early research with infection prophylaxis set the premise for national newborn screening programs, with a goal of starting penicillin prophylaxis by 2 months of age. Early recognition of sickle cell disease-related complications allowed for early intervention and improved outcomes. The use of the 23-valent pneumococcal vaccine in children with sickle cell disease and the broader use of the 7 and 13-valent in sickle cell in the general population further lowered pneumococcal infection rates. Advances in long-term therapies such as transfusion for primary and secondary stroke prevention and hydroxyurea for acute pain and acute chest prevention have most likely further decreased morbidity, mortality, and possibly improved quality of life. This study, published by Quinn et al. In Blood in 2010, demonstrates improved survival in the Dallas newborn screening cohort, which was comprised of 940 individuals. In this top panel on the left-hand side of your screen, you can see that as we moved from the early 60s, 70s, 80s, to the era in the 90s to the 2000s, we decreased infection rates and mortality primarily in children in the first 4 years of life. We can see this also in the lower right-hand panel, where we moved from the earliest reported cohort in the 70s in Jamaica to the cohort in the newborn screening comprehensive study in the 90s to the early 2000s, and then to the Dallas cohort. So we can say that through advances, primarily as related to clinical research, that we have markedly improved survival for the first 2 decades. Within the 60s, reporting that 40% of newborns would make it to 20 years of age, to now 93% of children born with sickle cell disease living to 18 years of age. However, in this cohort, in the study by Quinn, he also reported that there was an uptick in mortality starting at 19 years of age. This next slide demonstrates death certificate reports that were compiled by Dr. Alvarez and her colleagues and published in Pediatric Blood and Cancer in 2013. She looked at mortality in sickle cell disease across several different time periods. The blue bar representing 1979 to 1988, the orange bar 1989 to 1998, the green bar 1999 to 2003, and the purple bar 2004 to 2009. You can see that in the first several years of life until about 14 years of age, that throughout this time period, we've seen a marked decrease in death rates in children with sickle cell disease. But as we get into the 20s, 30s, and 40s, we start to see that we haven't made spectacular changes. So when you look at current trends in mortality and compare the 1999 to 2009 cohort to the 1978 to 1998 cohort, we can see that mortality decreased 61% in infants, 67% in children 1 to 4 years of age, and 22 to 35% in children 5 years to 19. But after 19 years of age, mortality increased from 0.6 to 1.4 per 100,000 in the 20 to 24 year group, with a similar increase seen in the next cohort as well. There was a tendency towards longer survival as more deaths occurred in the 55 to 74-year age groups, but it made us concerned that we really haven't seen a marked decrease in increase in survival in individuals with sickle cell disease, which is 48 at a median year for women with sickle cell disease, and survival at 42 years of age for men with sickle cell disease. One of the challenges is that transition is difficult for adolescents and young adults with sickle cell disease. We know that through national surveys, particularly of those with children with special needs, that there are factors associated with successful transition preparation. Female, gender, younger age, European American, non-Hispanic ethnicity, and not being within a level of poverty significantly increase your successful transition. However, these aren't factors commonly seen in patients with sickle cell disease. We know that we have an increasing patient population that's receiving chronic transfusion therapy, which is a plus, and this is primarily for primary and secondary stroke prevention. We also know that we have an increasing patient population receiving hydroxyurea therapy and a decreasing population coming from the pediatric groups with strokes and possibly other neurologic complications. And although these are all positive, we still have this pattern that is concerning across the lifespan. And actually, this is a typo here. This is a study by Blinder looking at 5 state third-party payer data published in Pediatric Blood and Cancer in 2013. This hashtag bar, blue line, is the frequency of transfusions across the lifespan, 0, 5, 10, and up to 50 years of age. We can see that there is a marked improvement in the use of chronic transfusion therapy, primarily as it relates to primary and secondary stroke prevention in the first 2 decades of life. We also see that there's an increased use of hydroxyurea therapy in this same time period. But this red-orange bar represents increased complications all total for those with sickle cell disease, primarily representing increased pain and increased acute chest syndrome. And just as we see the use of chronic therapy such as hydroxyurea and transfusion decrease, we start to see the increase in complications. This makes this age range, 17 to 21, very vulnerable, in the sense that just as more complications are occurring, we're also starting to see a decreased use in long-term therapies. We're also challenged with an increased portion of adolescents and young adults with sickle cell disease over the last 3 decades because we've identified them in the newborn period, we've started them on penicillin prophylaxis and used pneumococcal vaccines to decrease infection-related deaths, and then we've started to use many long-term therapies in this population as well. And we really don't have an adult healthcare system adequately prepared to take care of these children. We have developed resources in the pediatric population, primarily through comprehensive sickle cell centers that allow access to social work, nursing care, and multidiscipline teams to address many of the health care needs of individuals with sickle cell disease. But we haven't duplicated these resources in the adult care world. And we also know that there's increased pain and mortality in this transition age group, which further makes this a vulnerable population. And of course, the use of the long-term therapies in this age group with hydroxyurea and chronic transfusion also increases the complexity of care and the need for care coordination in this group of young adults or adolescents. But there are opportunities that we can take here, particularly with teenage women with sickle cell disease. Often, women with sickle cell disease in this age group, they are transitioned or transferred based on becoming pregnant, so that they have received less preparation than most living with sickle cell disease to prepare them to go to adult care services. There are things that we can do that start the conversation about contraception and reproductive choices that can happen shortly after puberty that will better prepare these young women to transition. We can incorporate reproductive counseling into patient education related to school, college planning, career planning, peer groups and socialization, particularly teen groups that are seen in many of our comprehensive sickle cell centers, and also discussions related to physical activities and competitive sports. And this also gives us an opportunity by talking about contraception and reproductive health to introduce additional healthcare providers, such as adolescent gynecologists, family practitioners, OBGYNs, to help not only better educate about reproductive health, but also help us provide a formal transition to adult care services for adolescents and young adults living with sickle cell disease. Again, this study by Blinder that shows treatment patterns by age, again emphasizes in this orange bar the increased complications that we see, particularly starting 15 to 20 years of age, and the majority of these complications are related to pain. Adolescents and young adults experiencing increased pain and increased hospitalization at these ages and increased length of stay for pain also provide a particular challenge, but also an opportunity for further exploration. Why are adolescents experiencing pain at higher rates? It may be that adolescents are experiencing increased pain associated with their menstrual cycles. And this was really reported initially in the late 70s, early 80s by Roland Scott and colleagues at Howard University that reported on 52 women living with sickle cell disease and showed that after menses onset, and particularly with changes in menstrual cycle, that 34% reported acute pain episodes with their periods. Jung and Tuck went on to show this similar menstrual pattern in women in with a cohort of 40 women. This was reported in 2002, and they saw a slight increase in the painful episodes associated with menses in this group. So really this gives us an opportunity to consider, when you're starting to see increased sickle cell disease-related pain in women experiencing menses, that this may be an opportunity to intervene with hormonal therapy to control their pain. Pregnancy in women with sickle cell disease is associated with significant morbidity and mortality, not only for the mother, but in addition for the fetus. And these two studies, one by Sun and the other by Villers, are two large cohorts that were published in fairly recent literature that I think provide good examples about the morbidity and mortality related to pregnancy in women with sickle cell disease. This first study by Sun and Jameson is a experience reported by their Grady cohort. It's a single institution study out of Atlanta looking at 127 deliveries between 1980 and 1999. The second study is out of Duke by Drs. Villers and James, and they use nationwide inpatient sample data from the Healthcare Cost and Utilization Project of the Agency for Healthcare Research and Quality, AHRQ. And they used 2000 to 2003 data on 18,000 deliveries to women with sickle cell disease. And the findings are really remarkable. We see that pregnancies in women with sickle cell disease are associated with multiple complications for the mothers. Antepartum hospitalization, preterm labor, preeclampsia, and increased risk for infection, not only pyelonephritis, but postpartum infection. We also see a number of increased complications related to sickle cell disease, increased acute pain episodes, and increased acute chest reported here as pneumonia. We know that there are also an increased risk from thrombosis in this population, and Dr. Maggie Ragney actually reported that not only are pregnant women with sickle cell disease at increased risk for DVT and PE, but those that have more severe complications of acute chest and acute pain are more likely to experience thrombotic complications. Also, there are complications on the fetal side. There is an increase in prematurity, in low birth weight babies, in intrauterine growth retardation, in intrauterine fetal death, and perinatal mortality to children born to mothers with sickle cell disease. There is a recent review in this year's May issue of Blood by Otang Tim, and it's a strong meta-analysis that addresses variation in the geographic socioeconomics by country and variation in phenotype across many studies. And what is most impressive is that in the SS type of sickle cell disease, they report a relative risk of maternal death of 5.98 and of stillbirth, 4-fold increase in women with SS, particularly compared to those with SC. interesting that in this study, there was only one death in an individual with SC, but most of them were in the SS group. Also, we see that this study also tried to control for the differences in socioeconomics across countries, but we still saw that despite these factors being considered, that maternal and fetal deaths remains problematic even in developed countries. What is underscored in this study, but really does not tease out in earlier studies, are two outcomes on the fetal side that deserve special attention. And that's the number of delayed hemolytic transfusion reactions in infants of mothers with sickle cell disease known to have red cell alloimmunization, and also neonatal abstinence syndrome in mothers using opioids frequently. And even though we know that these are still prevalent in our population, we don't have a lot of data related to the epidemiology of these two complications. We know that because of the increased morbidity and mortality associated with pregnancy and sickle cell disease, that these women should be considered high-risk pregnancies and be managed accordingly during pregnancy, and that whatever we can do for early identification of complications and early intervention, that we may improve outcomes in pregnant women with sickle cell disease. We really need to talk about fertility from the perspective of the use of contraception and the frequency of unplanned pregnancies, because there's really no good data on fertility in women with sickle cell disease. It would have been nice to have that be a part of a cohort for the comprehensive study for sickle cell disease, but that was actually not an outcome that was measured. But we do have several studies in the 80s and 90s that looked at contraception use and unplanned pregnancies in women with sickle cell disease. The first was a group out of Howard University that reported in 1984 that women with sickle cell disease used contraception a little bit lower than those of control, 33% compared to 66%. But when they did use, they primarily used oral contraceptive agents. In the UK, they reported that women with sickle cell disease used contraception at 91%, which is pretty high rate, and that there were those that decided to use contraception primarily used OCPs or combined hormonal contraception in the oral form. But there was also a cohort that used single agent progesterone in the form of depo-medroxyprogesterone in 17%. But still, in that cohort, 64% reported unplanned pregnancy. The other thing that's remarkable about these studies that needs to be mentioned that has not been reported and really investigated further is in that group, the UK group Howard et al. In 1993, and in the Knight-Madden study in 2009, a Jamaican study, they reported miscarriages in this group from 10 to 25%. Why is there a concern about the use of oral contraception or combined hormonal contraception in women with sickle cell disease? And I think it's primarily related to concern about an increase for thrombotic complication in this group of women. We know that many studies have reported sickle cell to be a relative pro-thrombotic hypercoagulable state. And we know that many studies have shown that there is an increased risk for venous thromboembolism in individuals with sickle cell disease across all age groups and in both genders. So are women with sickle cell disease on estrogen-containing oral contraception at increased risk for thrombotic complications? The problem with many of the reports in the literature is that the data is really all over the place. They use varying doses of estrogen. They look at varying sickle cell disease phenotypes mixing SS and SC. They have various follow-up periods, and many of the studies lack control groups. But it's interesting because some of them do address hematologic reported variables, where you would imagine that women on contraception may have less heavier periods, they may be less anemic, they may have a variation on their frequency of pain episodes, as we talked about pain being related to the menstrual cycle. And so further studies were performed, and the next slide really gives us an idea about what is in the literature, primarily from 1991 to 1997 across a hodgepodge of studies. The first study by Lucia et al. Really looked at high-dose estrogen use in 31 women with sickle cell disease with 70 patient years of follow-up. It was a prospective cohort, and there were no thrombotic complications reported in this group. However, there was one woman in the study that reported increased frequency of acute pain episodes. In a follow-up to that group, they expanded that study, included low-dose estrogen, and really more women for follow-up for 276 patient years of follow-up. Still, there were no reports of DVT or PE, and still there was that one patient that had an increased report of pain. The UK group actually reported in a retrospective fashion on 67 women with sickle cell disease for 148 patient years of follow-up, and reported 2 DVTs in that group, and a number of women who experienced increased pain. The last study requires a little bit of special attention because this was a study by Diabud in Panama, published in 1997, that looked at 14 women who were receiving low-dose estrogen compared to a group of women who were receiving progesterone alone and a group of women who had undergone hysterectomy for various reasons. And in this group, they not only showed that there were no thrombotic complications in the group that was exposed to low-dose estrogen, but they actually reported a decrease in painful episodes in that cohort. So this seems to be a theoretical risk of increased thrombotic complications in women with sickle cell disease receiving combined hormonal contraception. This has never been really reproduced or documented in any kind of clinical studies, and there are no strong clinical trials comparing these head-to-head, just that one study by Diabud that was non-randomized. However, we see many countries that adopted contraindications on OCP labeling to recommend not using estrogen-containing hormonal contraception in women with sickle cell disease. But that we know that presently the CDC currently rates combined hormonal contraception as adopted by the World Health Organization as a Category 2 agent. And this really gives me an opportunity to review what the different categories are and why this is relevant for sickle cell disease. So Category 1 is a condition for which there is no restriction for the use of the contraceptive method. Category 2 is a condition for which the advantages of using the method generally outweigh the theoretical or proven risk. And then Category 3 would be a condition for which the theoretical or proven risk usually outweigh the advantages. And then 4, a condition that represents an unacceptable health risk. So again, combination hormonal contraception or estrogen-containing therapy, primarily with low dose of estrogen, is rated as being a Category 2, a condition for which the advantages of using the method generally outweigh the theoretical or proven risk. So what about progesterone-only containing compounds? And really, some of this was inferred by studies that were done in 1972, where certain individuals thought that using testosterone, progesterone, could actually increase some of the hematologic parameters that would be found to be beneficial in those living with sickle cell disease. So they actually randomized individuals with sickle cell disease, both male and females, to receive these agents and reported a decrease in painful episodes, but no increase in hemoglobin and no increase in fetal hemoglobin. That contradicts the study by de Cuellar using DMPA 125 women in a randomized crossover fashion. He also found that the majority of women experienced decrease in their acute pain episodes, but they also found an increase in hemoglobin and fetal hemoglobin. The next several studies really outlined the use of progesterone only in the implantable agents, mainly addressing just women with the SS type of sickle cell disease. Again, there were some reports of decreased pain in that patient population, but the results regarding hematologic variables such as hemoglobin and hemoglobin F percentages really were not conclusive in these studies, probably due to the small sample sizes. What about women with sickle cell trait? We know that the group, Dr. Key has really reported on an increased rate of thrombotic complications in both men and women with sickle cell disease. What about women with sickle cell disease and hormonal contraception? And this is a study looking at 57 women that had DVT or PE, and then 185 who did not, and looked at the use of hormonal contraception and looking at sickle cell trait. And it really did imply that those with sickle cell trait who were using hormonal contraception were at a slightly increased risk for developing thrombotic complications. However, that was not statistically significant, and right now there are no contraindications to the use of combined hormonal contraception in women with sickle cell trait. So to summarize, the recommendations by the CDC adopted by WHO for contraceptive use in individuals with sickle cell disease, combined hormonal contraception, or estrogen-containing compounds. Sickle cell disease is considered a condition in which the advantages of using these agents generally outweigh the theoretical or proven risk. However, there is a subpopulation of women with sickle cell disease where you should seriously consider using progesterone-only compounds or avoiding low-dose estrogen-containing compounds. And those are women who have a history of a DVT or PE and women who have a history of stroke. For progesterone-only methods, it's free to offer women with sickle cell disease these agents without any restriction. And it's interesting that progesterone-only compounds have been the ones that have been the agents that have been reported to show some decrease in pain frequency in women with sickle cell disease, so may be the preferred method for those that have pain around their menses. For the copper IUD, sickle cell disease is considered a condition where the advantages of using this method outweigh the risk. There is a general concern about the increased risk of blood loss with copper IUDs. Levonorgestrel IUD, there is no restriction for this in sickle cell disease. However, if there's a history of stroke or venous thromboembolism, there should be some considerations about whether or not to use these IUDs in that subpopulation. But generally, these methods are well tolerated by women with sickle cell disease, and at least in our institution seems to be a method of choice, particularly for adolescent females. For barrier methods, there's no restriction, and for other sterilization methods, of course, there's no restriction for those with sickle cell disease. This brings us to the evidence-based management of sickle cell disease, recently published in September by the National Heart, Lung, and Blood Institute of NIH. This was an expert panel report, and the reason that this guideline was developed was because many feel as though that the recent advances in the management of sickle cell disease have not been widely adopted. And this is primarily due to not only the low rate of hydroxyurea use in individuals living with sickle cell disease, but also other practices such as stroke risk screening in the pediatric population. There are not best practices for clinical care that are widely disseminated, and there's a perceived decrease in the number of sickle cell experts available to take care, particularly of adults living with sickle cell disease. So the purpose of the guideline was to synthesize the available scientific evidence on sickle cell disease and offer guidance primarily to primary care providers. It was not intended to be prescriptive, but simply to provide guidance, and the grade of evidence was weighted based on the quality of the data, and the guideline specifically said that if there was not high quality evidence, the quality indicators should not be linked to those parameters. So the management of sickle cell disease, the summary of the evidence-based report, is an excellent resource. It really kind of summarizes the salient features of this guideline, but the full guideline is available on NIH's website. And I'm only going to talk about the guideline as it relates to reproductive concerns. And one of the recommendations that I'll highlight is kind of what we just reviewed, is that the group decided to adapt the recommendations that were made by the World Health Organization and the CDC, and they recommend progestin-only contraception, pills, injection, implants, the levonorgestrel IUD, and barium methods to be used in women with sickle cell disease without any restrictions or concerns. And if the benefits are considered to outweigh the risks, using combined hormonal contraception, low-dose estrogen may be used in women with sickle cell disease, but understanding that there's a subpopulation with DVTs and PEs and strokes that should be considered primarily for progesterone-only compounds first. So to summarize, women with sickle cell disease experience unplanned or unintended pregnancies, with some rates being as high as 60%. There was a recent update of the UK report that actually looked at this same cohort over time that they reported initially in 1993 and found that the rate of unintended pregnancies had gone from the high 60s to the low 50s in their population. Studies of progestin-only compounds in women with sickle cell disease have not demonstrated increased risk for thrombosis and may be associated with decreased sickle cell pain. And studies addressing risk for venous thromboembolism in women with sickle cell disease receiving combined hormonal contraception are limited. However, women with sickle cell disease may not be at increased risk for VTE when exposed to low-dose estrogen-containing compounds, but with the caveat that if there are women with a history of VTE, a history of CNS complications, or also those with permanent venous access catheters who might be at increased risk for line-associated clots, that you really should consider progesterone only in those groups. I think that really one of the big take-home messages for this guideline is really nice advice around reproductive counseling for this population of young adults and adolescents with sickle cell disease. And that really they emphasize that every woman or man or couple affected by sickle cell disease should have a reproductive life plan. And as part of primary care visits, we should provide risk assessment and education and health promotional counseling or refer to these women where they can get good counseling about recommendations to reduce reproductive risk and improve pregnancy outcomes. We should provide contraception counseling, and if desired, to prevent unintended pregnancy. And if pregnancy is desired, then we should provide preconception counseling. I think that this is a really important point for us. It allows us to really include other providers in the management of teenagers and young adults with sickle cell disease, and particularly for our young women to include the gynecologists, the OBGYNs in their care and actually maybe as part of their transition plans. The other thing that this goes on to really emphasize is that women who are interested in becoming pregnant, and if they have been transfused, that we really should look to see whether or not they have the presence of red cell antibodies. We know that the Rh group antibodies are very prevalent in individuals with sickle cell disease who have been exposed to red cell units, and that these are very, very problematic for delayed hemolytic disease in the newborn. So that we should really monitor pregnancies closely for this and counsel women accordingly. We also have to talk about the high risk of pregnancy being associated with stillbirth, but also maternal death, and that we should, particularly in women who require chronic opioids or frequent opioids during pregnancy, then we should monitor for neonatal withdrawal in their newborns. Shifting gears, I'm going to talk about the use of hydroxyurea therapy in women with sickle cell disease. We know that this multi-center trial for sickle cell disease reported on 299 individuals who were randomized to receive hydroxyurea versus placebo. And in the hydroxyurea group, they experienced decreased pain, decreased acute chest syndrome, and a reduced need for transfusion therapy. Even though the FDA then recommended the use of hydroxyurea in adults with sickle cell disease to decrease pain, we did not have similar studies in the pediatric age group, but looked to reports to see whether or not there were any particular concerns with hydroxyurea use in this young age. The Hug Kids study monitored growth in children with sickle cell disease and did not find any adverse outcomes. And the Baby Hug trial looked to see whether or not starting hydroxyurea within the first year of life could reduce the adverse outcome in chronic organ damage to the spleen and to the kidney. Even though that it did not really reach that level of evidence, we did see a decrease in the frequency of pain and acute chest as related to hospitalization in young children with sickle cell disease with the use of hydroxyurea early in life. The hydroxyurea recommendations in the expert panel report really have gone to broaden the indication for hydroxyurea therapy, not to just decrease pain in those that have frequent pain and a frequent acute chest syndrome, but really to offer hydroxyurea to adults with sickle cell disease who have sickle cell-associated pain that interferes in their daily activities and with their quality of life. Also, if those individuals have symptomatic chronic anemia, then we should offer hydroxyurea as well. And most importantly, that families of infants 9 months of age and older should be offered hydroxyurea therapy, thereby really broadening the eligibility criteria for hydroxyurea use in individuals with sickle cell disease. So what are the barriers? Why are approximately only 36% of those with sickle cell disease having access to hydroxyurea therapy? And there are many, many concerns. There were concerns about taking a chemotherapeutic agent like hydroxyurea across the lifespan. There were concerns about fertility, particularly in males. And there was also concern that hydroxyurea had teratogenic effects, and that there was going to be concern about the use for contraception in females. There was a national toxicology monograph that looked at hydroxyurea and developmental impact, and specifically as it relates to sickle cell disease. And they expressed concern that exposure of pregnant women to hydroxyurea may result in birth defects, abnormalities of fetal growth, or abnormal postnatal development. And subsequently, hydroxyurea should not be used in pregnant women. So what is the biologic plausibility that hydroxyurea could cause these problems, these teratogenic effects? And hydroxyurea is an S-phase agent that inhibits DNA synthesis through ribonucleotide reductase enzyme inhibition. And we see common toxicities that occur in rapidly dividing cells, like a decrease in hemoglobin, a decrease in absolute neutrophil count, and in platelet count as it relates to myelosuppression. So is hydroxyurea a human teratogen? And what are the outcomes of fetuses exposed to hydroxyurea in utero? Well, there are multiple case reports of healthy offspring of women who were taking hydroxyurea during pregnancy, both with sickle cell disease and with myeloproliferative syndromes. But there's pretty impressive animal data that shows that hydroxyurea causes birth defects, reduces the number of live births, and causes abnormalities in fetal growth. So are there reports of hydroxyurea use in pregnancy in women with sickle cell disease? And this table outlines the use and exposure of fetuses to hydroxyurea in the first trimester of therapy, in the first trimester of pregnancy. And we can see that there were approximately 7 cases, and that out of those, the women elected to terminate in 2, but that normal children were born. Now, this doesn't mean that hydroxyurea should be recommended for use in pregnancy. It just reports that those who have been exposed to hydroxyurea during pregnancy have not had children with congenital abnormalities. This data is also similar to data reported in exposure to hydroxyurea during pregnancies in those with myeloproliferative syndromes, JMML, CMML, and we can see that out of these 31 that there really had a reduced number of births, primarily due to spontaneous or voluntary abortion, but not due to spontaneous loss as frequently. There were 2 in utero fetal demise, 1 in a woman with sickle cell disease who had a placental hemorrhage, but that most of these children were born, these newborns were born without any congenital abnormalities. What about the data that supports that women should not breastfeed while on hydroxyurea therapy? There's one clinical study of a woman who was receiving 1,500 milligrams of hydroxyurea per day, and they sampled breast milk to see how much hydroxyurea was in the breast milk, and they found that there could be exposure of 3 to 4 milligrams per day of hydroxyurea to nursing infants, which is a very, very low dose. But based on this, they recommended that women who were breastfeeding not take hydroxyurea. Again, many of these studies, the animal models were done using hydroxyurea at very, very high doses and not at similar doses that we use therapeutically for those with sickle cell disease. I think that even though we know that the current recommendations are for women with sickle cell disease who are considering starting hydroxyurea therapy, that you should do a pregnancy test before you actually start therapy, and that we should very closely monitor those who wish to become pregnant, and if they wish to become pregnant, then we should stop hydroxyurea 2 months before, and if they are pregnant or breastfeeding, that we should discontinue hydroxyurea therapy. Although those are the current recommendations, it really comes to mind and makes us wonder, based on the data that we see, whether or not we are limiting a potentially beneficial therapy to women with sickle cell disease in reproductive years. If you would imagine stopping hydroxyurea therapy 2 months before you desire to become pregnant, it may take you a year to become pregnant, get you through the pregnancy, and then with breastfeeding, that you could be off of hydroxyurea for many, many years. So I really think that studies related to teratogenicity and to hydroxyurea in breast milk, those studies should be repeated to make sure that we're giving people the best advice. So in summary, we know that the proportion of individuals with sickle cell disease in the adolescent and young adult age group is increasing, primarily through early diagnosis, through newborn screening, the early use of penicillin prophylaxis and pneumococcal vaccines that has resulted in increased survival in this group. that the proportion of individuals with sickle cell disease who are receiving long-term therapy is increasing, as we see chronic transfusion use for primary and secondary stroke prevention, and the broader use of hydroxyurea presently as it's recommended in our guideline. Adolescent girls and young women need safe and effective contraceptive methods to prevent unintended pregnancy, and this is very much demonstrated in the studies that continue to report unintended or unplanned pregnancy at about 50% in the sickle cell population. In some of our geographic areas, this is similar to those living without sickle cell disease, but in other areas, this is higher. Women with sickle cell disease and sickle cell trait who wish to avoid pregnancy should receive contraception counseling that includes options for hormonal contraceptive agents in addition to barrier methods, and that we should not be specifically withholding estrogen-containing contraceptive agents to women with sickle cell disease unless thrombotic complications exist or if there is a permanent catheter in place. Hormonal contraception selection should be considered in women who seem to have increased pain associated with their menstrual cycle, particularly progesterone-only compounds. And the combined hormonal contraception should be safe in adolescents and young adults with sickle cell disease, again, who have not had a stroke or a thromboembolic complication. Hormonal contraception appears to be safe in women with sickle cell trait. However, there are studies that suggest that there might be a trend towards an increased risk for thrombotic, for venous thromboembolism in those who are receiving combined hormonal contraception, and that these studies need to be duplicated in order to determine what the real risk is. Women with sickle cell disease who wish to become pregnant who are receiving hydroxyurea should discontinue according to the guidelines as those who are breastfeeding. But we do know that we need further research to make sure that we're making the right recommendation. So again, research is needed to determine the impact of hydroxyurea on conception, pregnancy complications and outcomes, fetal growth and development, and neonatal exposure through human breast milk. We really need a surveillance system for individuals living with sickle cell disease, particularly those receiving long-term therapies, to really understand what, whether or not there are changes in fertility, changes related to menopause in women with sickle cell disease, particularly those subpopulations that are receiving chronic therapies such as hydroxyurea and chronic transfusion therapy, and not to speak of, because we don't have time to really address it today, but also a cure for sickle cell disease, and that's stem cell transplantation. And there's a great need to look at maintaining fertility in those populations. With that, I would like to turn the webinar back over to Dr. Lockhart.
Thank you very much, Dr. Smith-Whitley, for your excellent presentation. Next slide, please. For participants of this webinar interested in receiving continuing education credits, you will receive an email with a link which will direct you to the post-webinar test and evaluation. You will also receive instructions for how to receive your educational credit certificate. Next slide. At this time, we will proceed with the question and answer part of our program. As a reminder, participants can submit questions via the chat box in your GoToWebinar control panel on the right-hand side of your screen. Questions will be answered in the order they are received. And we've already been receiving some excellent questions throughout the webinar. So I'll start with the first one. Dr. Smith-Whitley, there was a question regarding the incidence of complications in pregnancy. Is there, in particular, an overall incidence of complications in pregnancy for patients who have sickle cell disease? And some of the complications you presented, are there significant ranges in which we can expect those complications to present?
Well, that's a very interesting question. And this this nice meta-analysis by the UK group that was published in Blood in May of 2015 really gives you nice relative risk rates for various complications, and just some of them, preeclampsia in women with sickle cell disease, particularly the SS type, is twofold higher compared to those without sickle cell disease. And also the fetal demise in those with sickle cell disease occurring at around the same relative risk rate for those with the SS type. You're asking a good question about the frequency specifically across the different weeks of gestation, and I'm not clear that anybody has specifically reported at what point these issues become problematic. I'm sure there's something out there, but I'm not aware. Maybe there's another participant that knows whether or not this is done by gestational age. But this is something that needs to be attended to so that women early in pregnancy with sickle cell disease can get to knowledgeable OBGYNs that can appropriately monitor them throughout the pregnancy for all of these complications.
Good, good. Another question that was posed was regarding fetal complications that you were speaking on. Is there an increased incidence of placental infarcts in sickle cell disease that could account for those complications? And has anyone looked at the placental pathology in these pregnancies?
And that's another good question. And I know there have been studies looking at placental pathology in individuals with sickle cell disease. There is a strong theoretical risk that placental insufficiency or placental ischemia leads to many of these complications. And maybe that's why we're seeing some variability in rate of complications in SS as compared to SC. I don't know that there have been any recent pathological or pathology studies really looking at the placenta, the numbers of placenta in a large cohort, but definitely there's small studies that have shown that there are changes in the placenta in women with sickle cell disease.
It would be interesting to see that large cohort. Yeah. So regarding some of the epidemiologic data on mortality, curious about how deaths due to sickle cell disease were defined. Could you speak on that at all?
Oh, you know, that's a very good question. I wish Dr. Lanscrom was on the phone because she is my go-to expert in sickle cell disease and pregnancy. One of the things that is very clear in that large study, there were 10 deaths that were reported. Some of the deaths seem to be due to hemorrhage, and so it's not clear whether or not all of that was supposed to be related to underlying sickle cell complications as it relates to pneumonia. But it seems that hemorrhage, infarction, thrombotic complications were prominent in those deaths.
Interesting. Another question was coming around to looking at the question of unintended pregnancy in sickle cell disease patients. Specifically, had there been any trends that were noted looking at age groups? It's a reasonable assumption that teens may be more vulnerable to this, but curious about what the data showed.
Well, I think that this also brings up another point that I really need to emphasize, is that we really don't have good data on fertility in women with sickle cell disease. So we don't know the numbers of women over the lifespan who have tried to get pregnant but could not get pregnant. We only have these quote-unquote unplanned or unintended pregnancies reported out, and most of this is really done by surveys, and some of them in a retrospective fashion. So I really think that the data on unintended or unplanned pregnancies needs to be done in a nice, well-defined cohort of individuals with sickle cell disease across different age groups. Your point is well taken. It's probably going to be very different in the teenage age group, than in the late adult age group, which we see even in the general population. It would be fascinating to see that data in sickle cell, and I just see that it's there.
All right. We've received a couple questions actually looking at or inquiring about pregnancy termination in women with sickle cell disease, possibly sickle cell trait, looking at either morning after pills or actual abortion procedures. Can you speak at all about what we should know about the risks of either one of those procedures?
I could only find a couple of case reports related to the morning after pill. I did not see anything in particular that identified a risk factor for individuals with sickle cell disease, even though you may think that there might be an increased rate of pain with exposure to morning after, possibly, depending on the type of follow-up that's done on those patients. For elective termination of pregnancy, I can say only through my personal experience with this population that it seems as though they experience increased pain around these events. I would recommend that if these young women are deciding to have elective termination under general anesthesia, that the guidelines for transfusing to a hemoglobin of 10 in the SS population be followed to avoid acute chest syndrome. But other than those two specific nuances, I have not seen any general recommendations for that group of women with the morning after pill or elective termination of pregnancy.
All right. Well, I think we have time for one more question, and it's actually a composite question from a few of our attendees asking about hydroxyurea dosage, any recommendations for that, and monitoring hemoglobin F levels. Are there any specific hemoglobin F levels that you're aiming for in these patients?
Oh, that's a very good question. You know, the guideline recommends starting children, I believe, at 20 milligrams per kilogram of hydroxyurea and adults at 15. The expert panel report also talks about titrating to maximum tolerated dose in order to actually increase the dose until you start to see mild neutropenia, and that certain groups are looking at the guidelines of whether or not the goal of hydroxyurea therapy should be set at an absolute hemoglobin value or an absolute delta, a change in hemoglobin for certain individuals, or an absolute increase or delta in the fetal hemoglobin. And right now, I don't believe the expert panel report targets any of those two outcomes, but I would imagine that individual groups are going to start looking at whether or not it's feasible for hydroxyurea protocols to set either a hemoglobin value or a hemoglobin F value as a goal for certain hydroxyurea protocols individualized for patients.
Very interesting. So at this point, we're going to close up the question and answer period. I will encourage those that for those attendees whom we weren't able to get to your questions, we would encourage you to visit our Ask the Experts feature on our website, fwgbd.org, and submit your question online. Next slide, please. Next slide. Thank you. I'd also like to let our attendees know about our upcoming Friday Satellite Symposium at the 57th Annual American Society of Hematology meeting on December 4th in Orlando, Florida. We're excited about this symposium. It will be an in-depth look at emerging science and technology to improve the lives of women with blood disorders. If you're going to be in Orlando, we would love to have you join us. Next slide. This concludes our webinar. You will be able to review this webinar for your reference or share today's proceedings with your colleagues by logging into MyFWG and accessing this webinar under the My Past Webinars section on our website. We thank you all for your attendance and participation today, and we look forward to your return for future Foundation webinars.